The Substance Abuse and Mental Health Services Administration, or SAMHSA, created the Wellness Initiative because people with mental and/or substance use disorders tend to die years earlier than the general population. Studies show this is mostly due to preventable and treatable conditions such as diabetes, heart disease, and cancer, which can be improved by healthy eating, increased physical activity, and smoking cessation. Focusing on health and wellness is particularly important for people with or at risk for mental and/or substance use disorders so they can live long, healthy lives. SAMHSA's goal is to help individuals, families, providers, and communities improve whole health outcomes. Keep listening to learn more about wellness and tips you can apply in your life.
Hello everyone, my name is Kathy Cave and I'm co-director of SAMHSA's Program to Achieve Wellness. Welcome to our 3-part podcast series on non-opioid alternative treatments for chronic pain. For the first podcast in our series, we are joined by Mel Pol, who's the Chief Medical Officer of Las Vegas Recovery Center, and Niki Miller, who is a Senior Research Associate at Advocates for Human Potential. We're first going to hear from Niki about her experiences, have an opportunity for her to share her wisdom with us, with more than 30 years of experience working in communities and systems to improve the lives of individuals with multiple vulnerabilities. She was founding executive director of New Hampshire Task Force on Women in Recovery, nationally recognized advocates for women, girls, and families dealing with addiction, trauma, and mental health issues. She also served as administrator of women offenders for the state of New Hampshire. Recent projects include developing promising practice guidelines for medication-assisted treatment with justice populations and writer for SAMHSA's online shared decision-making tool. Today, she's going to start off our conversation on alternatives to pain management, talking about the scope of the challenge for individuals with mental illness. Niki, thank you for coming.
Well, thank you, Kathy, for that terrific introduction. I'm glad to be here. I'm excited to hear from Dr. Pohl and to talk to all of you about an issue that is a very serious concern for communities across the country. I'm delighted to share information and ideas with you about chronic pain management for individuals with serious mental health disorders. In my work, I specialize in developing practical tools that help professionals apply research and best practices to the everyday interactions they have with the people they serve. I have extensive experience with prevention and treatment of opioid use disorders, and also with approaches that support shared decision-making in behavioral health and wellness and recovery self-management. I'm also a person in long-term co-occurring recovery from mental illness and addiction, who happens to also live with chronic pain. A physician who I admire very much once said something that resonated very deeply with my own experience of chronic pain. He said that in medicine, it is usually a mistake to attribute a condition to any single cause. That rings true for me. Most days, my experience of chronic pain is kind of like white noise. It's always in the background, but I'm used to it. Some days it's hardly noticeable. But then there are those difficult days when I might have more than one type of pain going on. And that's when something like lack of sleep or the onset of a headache or even a high pollen count can just sort of push me right over my threshold. On those days, that white noise of chronic pain becomes so loud that it drowns out everything else in my life. But just as a combination of factors generally trigger intolerable levels of pain, for me, it usually takes a combination of remedies to find adequate relief. There are a number of different approaches that different people respond to when it comes to chronic pain. The more options people have, the better they are able to discover the things that actually work for them best. Unfortunately, in recent years, an over-reliance on opioid prescribing for chronic pain has contributed to a number of unintended consequences as I'm sure you are well aware. Some of these consequences include a very sharp rise in opioid addiction rates and higher rates of opioid overdose fatalities than have ever been seen before. There's been a fourfold increase over the last 15 years in the prescribing of opioid analgesics, or opioid pain killers as they're sometimes called. Nationally, overdose fatalities attributed to the commonly prescribed opioid analgesics exceed heroin overdose fatalities. They've been exceeding these heroin overdose fatalities for a number of years. But at the same time, both the demand and the supply of illicit opioids has increased while prices have dropped and the potency has risen, often in response to attempts to rein in the accessibility of their pharmaceutical counterparts. So patients who are prescribed opioids for legitimate medical reasons and take them exactly as directed can and do become physically dependent on these drugs. Today, an individual who's addicted to opioids is way more likely to have started out using a prescribed pain medication than to have started out using an illicit drug of some sort. Now, this is a big departure from decades of drug use trends in the United States. One recent study of patients in opioid treatment programs found that more than a third of them reported their reasons for seeking treatment was related to opioid use for physical pain. For many people, taking opioid medications for pain can be a direct route to physical dependency that quickly develops into an addiction, especially when they have certain risk factors that increase their susceptibility to addiction in the first place. Yet, pain management is a very real issue for many people, including those with mental health issues and people in recovery from substance abuse. They require information and options that can improve their quality of life. There's no doubt that opioids are extremely effective at changing the body and brain's response to pain. They provide significant relief to untold numbers of individuals experiencing severe levels of acute pain. However, today we know that the body and brain are also very efficient at adapting to the presence of opioids in a pretty short period of time. The result is that the same dose that once offered relief is no longer effective. Higher doses are required to do the job, but then it doesn't take very long for the body and brain to marshal their response when more opioids are introduced into the system, and the cycle starts again. This phenomenon is known as opioid tolerance, and it is one of the big reasons that long-term use of opioids to manage chronic pain often creates a situation where there are diminishing returns and increasingly serious risks. Now, fortunately, in 2016, the Centers for Disease Control and Prevention released new updated guidelines for prescribing opioids for chronic pain. And these were based on current research, which demonstrates that the benefits are pretty limited for long-term use and management of chronic pain. The new guidelines emphasize a need for providers to fully advise patients about the risks involved and all the alternative approaches that are available to them. These practices ensure patients are equipped to make informed decisions together with their healthcare providers. Now, throughout this entire podcast series, we're going to hear more about alternative approaches from highly qualified practitioners and from some individuals who are recovering from serious mental health disorders, living with chronic pain, and maintaining a level of wellness that has improved their quality of life. They'll share some good information about the way these two recoveries interact and the variety of options they have discovered that help them achieve wellness. But before we do, I'd like to discuss a few compounding risk factors that can affect people with mental illness and elevate the risks associated with treating chronic pain with opioid medications. One factor that contributes to the development of a drug or alcohol problem is the reinforcing effects that occur when people use a substance. Now, opioids in and of themselves are one of the most highly reinforcing drugs anyone can possibly assume. Their euphoric effects can lift up your spirits, their sedative effects can soothe your nerves, and suddenly things that usually cause you all kinds of emotional distress, they don't seem to bother you too much at all anymore. So people who have never used drugs that might have a depressive disorder or an anxiety disorder, or any number of mental health symptoms that cause them distress, tend to be a little more susceptible to developing a problem if they experience positive effects that powerfully reinforce taking the drug. There's also a significant number of individuals with mental health disorders who've had a problem in the past with substance abuse at some point, which might have been very mild. It could have been severe, it could be undiagnosed, or it could be in remission. Many people who are in long-term recovery from substance use disorders also have serious mental health disorders. Pain management is a critical issue for these individuals. When they do not get the specialized care that they require, it can contribute to relapse, and that can lead to devastating consequences, including fatality. Now, both types of disorders share some common risk factors. Studies have documented high rates of childhood abuse, exposure to violence, and exposure to multiple family stressors among both groups. Heredity has also been identified as a very influential risk factor for both mental health and substance use disorders. Research suggests there's a very complex relationship between substance abuse, mental health, chronic pain, and opioid use. An estimated 29 to 60% of people with opioid addiction also have chronic pain. A recent study was of 825 people in opioid treatment programs, and it found that almost half of them reported severe psychological distress, and 37% had attempted suicide. 42% had a history of post-traumatic stress disorder, and about a third met the criteria for major depression. Another similar study found the rates of attention deficit disorder was about 20%, and bipolar disorder about 43%, but several of the people that they surveyed and sampled met the criteria for both ADD and bipolar disorder. And the research on overdose fatalities also indicates that rates are higher among people with mental health disorders. An overdose risk assessment that was recently developed and tested using Veterans Health Administration data is the purpose of it is to identify high-risk medical and behavioral health conditions. So patients who have these conditions, if they're prescribed opioids, they also receive some risk reduction counseling and are closely monitored. Two of the substantially weighted risk factors on this screening tool are having a bipolar disorder or schizophrenia and current use of a prescribed antidepressant. All this information is very important to consider when discussing the risks and the benefits of the various treatment alternatives available to people with chronic pain. It's also tremendously helpful to talk with people about how their mental health symptoms and pain levels interact. I'll share a personal example of just how beneficial and important this approach can be. I have post-traumatic stress disorder, and at one time my symptoms were really quite severe. But I am fortunate enough to have recovered significantly, and I really only have to deal with one symptom on a regular basis. And that symptom is sleep disturbance. I still have a hard time falling asleep, staying asleep, and I have difficulty getting enough sleep. Well, when I discussed this with an informed pain management specialist, she told me that sleep deprivation decreases your pain threshold and it exacerbates pain. And she also said the effect was more pronounced among women than men. Now, since that time, I have found through trial and error that catching up on sleep has a profound effect on my pain levels. And it's now my first line of defense when pain levels become too high or intolerable or difficult to deal with. Now, as a person in addiction recovery, I don't think I can overstate how important that lifeline she threw me was when she informed me of this stuff and took the time to work with me on these issues. Well, the next speaker I'm also really looking forward to hearing because he's one of those beacons of light that people like me feel incredibly fortunate to encounter as we sort of stumble along our pathway to wellness, looking for solutions. And I'm really looking forward to hearing from him. So I want to thank you so much for your attention to this issue and for all you do to help people make wellness a reality.
Niki, thank you so much for sharing your wisdom with us today and for really laying the foundation for not only the rest of today's conversation, but for our future podcasts in this series. Next, we're going to hear from Mel Pol, who's going to expand upon some of the points that you shared with us already and add his conversation to really strengthen what we're going to hear today about chronic pain and strengthen our understanding about chronic pain. We are pleased to have Dr. Mel Pol with us today. As I mentioned, he's a board-certified family practitioner. He is the Chief Medical Officer of the Las Vegas Recovery Center. Dr. Pohl was a major force in developing the Recovery Center's chronic pain recovery program. He is certified by the American Board of Addiction Medicine. He is author of A Day Without Pain and The Pain Antidote: Stop Suffering from Chronic Pain, Avoid Addiction to Painkillers, and Reclaim Your Life. He recently filmed a show for PBS on chronic pain, which aired around the country in August of 2016. Mel has substantial expertise that he's generous enough to share with us today, really highlighting the role of science in chronic pain management. Mel?
Thank you for the introduction, Kathy, and for kicking off the conversation, Niki. It was a wonderful opening to this very complex subject. I'm pleased to be here today and hope that what we share can help make a difference for providers and the individuals they serve all around the country. When having this discussion around chronic pain, it's important to ask, how have we gone wrong with our treatment of chronic pain? There actually are some fundamental misunderstandings that have led us to where we are today, with 2 million Americans dependent on opioids, thousands dying from overdoses every year, and millions more struggling with the suffering of living with chronic pain. So many of our patients who have serious mental illness and substance use disorders also suffer from co-occurring chronic pain. So how did we get here? We are a culture who abhors feeling pain. We avoid it at all costs. We somehow feel we should be free of it. Of course, that's the first and most problematic misunderstanding about life. We've all heard pain is inevitable. We've been told this over and over. But also that suffering is optional. And it turns out the more we fight against or resist pain, the more we suffer with tight muscles and negative attitudes. The biggest problem with our approach to pain, both patients and clinicians, is that we confuse acute pain with chronic pain, as if chronic pain is just a longer version of acute pain. If we take the next steps in this ill-conceived comparison, we ought to be able to find the source of the chronic pain as we can acute pain, with x-rays, MRIs, CAT scans, and the like, since the pain was caused by tissue damage. In fact, the more tissue damage, the worse the pain should be, right? Once we've diagnosed the pain, as with acute pain, we should be able to fix the problem by manipulating or cutting out the damaged tissue, causing healing and the resolution of the pain. And the final misconception is that if there's no evidence of tissue damage, then the pain must not be real. Turns out these basic misunderstandings have led us to medicate, operate, and ultimately give up on patients who don't get better. Tragically, we as clinicians, and often the patient themselves, aren't sure the pain is real. So let's start with some essential truths about chronic pain. And the first one is, the pain is real. In fact, all pain is real. The nature of chronic pain is different than acute pain since it's not related to tissue damage, but rather to changes in the brain and the nervous system. Rather than just more acute pain, chronic pain is a totally different process. Acute pain, think of it as an alarm clock going off. It warns us of actual or potential tissue damage. It warns us something is wrong. The problem is in the hardware of the nervous system. This transient activation of the nervous system ends when the cause of the pain ceases. If you have a nail in your finger, removing the nail eventually causes the pain to go away, or an infection subsides, or fractured bones come together and the tissue heals. Chronic pain, on the other hand, is a problem with the software of the nervous system, the processing areas of the brain and the spinal column and the nerves that supply them. It's as if the alarm clock has gone off and we are awake, but the clock just keeps buzzing, becoming annoying and frustrating. With chronic pain, as with a buzzing alarm clock that won't shut off, the pain is not serving the function it was created for. It is maladaptive and a source of irritation, but no less real than acute pain. In actual fact, the brain has become more sensitive to the pain signal coming from other parts of the body. Over time, that signal registers in the person's brain, and the brain believes that there's something really wrong. The brain believes that the signal means that something is physiologically significant. For example, my patient tells me, my bones are degenerating, or my head is exploding. I have chronic back pain and my back throbs from time to time related to the position that I'm in. The pain in my back and in the spine of many people and in their head is not necessary to inform us about an anatomical problem, like a broken bone. Its significance is, however, that it impacts every aspect of the person's quality of life on a daily basis. Unfortunately, it is not uncommon for physicians and other prescribers, families, and even patients themselves to misunderstand the nature of this chronic pain. Diseases like fibromyalgia and migraine headaches are often misinterpreted as malingering or, quote, psychosomatic illnesses, somehow less real. Patients' report of pain are not believed. They are judged, and the cost of this disbelief is significant. Essentially, the validity of the patient's word is doubted, and the patient begins to doubt his or her own experience, and this can be devastating. Pain is a subjective experience, so it can't be assessed effectively without input from the patient. We can't hook the patient up to a painometer or a dolorimeter, like a blood pressure machine, and calibrate the experience. So, the pain is what the patient says it is, and it turns out that some feel more pain than others. There is good information about the effects of genetics and trauma on the central nervous system and the way certain neurotransmitters are metabolized differently in different people, causing some to be more sensitive to a stimulus than others. There is a kind of switchboard in our nervous system that can make the pain bigger or smaller. This switchboard is mediated by an enzyme called, big word, catechol O-methyltransferase, or COMT. For those of you that have medical backgrounds, COMT is an enzyme that metabolizes dopamine and adrenaline. Dopamine, many of you know, is the neurotransmitter of well-being. Adrenaline is the neurotransmitter associated with excitement and alertness. COMT is different in different people. In some people, it causes the pain signal to get huge and for them to feel more pain. In others, it keeps the signal low and insignificant. Let's say someone has the variant of COMT that makes touching him or her lightly with little pressure cause excruciating pain. If this person was sitting here complaining vehemently about this pain from being touched lightly, what would we say about this person? Perhaps that he or she is a wuss, a wimp? We would judge him or her. We do judge him or her. And we judge these people who are sensitive to pain, even though, as I've just explained, it's actually related to a physiologic phenomenon that is a response to variants of this enzyme system. There are two things that influence the type of COMT and pain sensitivity one experiences. As we mentioned, Niki and I, the first is genetics. In other words, people are born with sensitivity to pain just like eye color. The second factor influencing COMT variants is the experience of trauma. People who have had sexual, emotional, or physical trauma, or all three, as often is the case, as well as people who have had combat experience and witnessed horrible things in their lives like first responders or veterans, these people experience more pain. Living through trauma sets the volume knob inside the pain center on high. This phenomenon is referred to as central sensitization. It occurs in the brain and nervous system where the signal intensity inside the midbrain's pain centers, called the amygdala, the nucleus accumbens, and the insula, those signals are turned up. The volume in that part of the brain is turned up. People with this form of chronic pain are suffering and frequently present to clinicians seeking treatment and pain relief. They are often alienated from families and friends, and more importantly, at this point, from the prescriber of their medications. It is said that these patients have a better relationship with the drug than with the doctor. And this disconnect is a significant element of the crisis faced today in effectively treating chronic pain with medication. Some people who have chronic pain either shrug it off and we call them strong and tough, while others suffer more because for them the suffering is bigger than the pain. Suffering is the human response to the experience of pain. In order to be effective in our treatment, rather than judging, we must align with the patient and they must perceive that we are on their side. In medical school, I remember being taught that if you have tissue damage, you have pain, and if you don't have tissue damage, you must be making it up. That's simply not the truth. The second truth is that emotions and thoughts drive the experience of chronic pain. One of the questions that I frequently get asked by referring clinicians is it real pain or emotional pain? And my answer is always the same. The answer is yes. Yes, it's real pain, and yes, it's emotional pain, because thoughts and emotions drive the experience of chronic pain. This is where we really do patients an injustice. It's as if we judge emotions as not real or legitimate. How many people suffer from depressed feelings, or anxiety, or fear, or anger? Certainly with mental illness people do, but actually we all do. These are human emotions. The physiology of thoughts and emotions is well understood. It's all happening inside our 50 billion brain cells, trillions of connections, hundreds of neurotransmitters, including dopamine, serotonin, and a group of pain-relieving chemicals you all well know, known as endorphins. And they're all communicating with each other every moment of every minute of every day. Pain lives in the brain along with these emotions, and there is serious data showing that when somebody has a broken ankle, a particular part of the brain called the thalamus lights up on functional MRI scans. When someone has back pain or someone has chronic headaches or a sore neck or shoulder that lasts longer than 6 months, which is chronic pain definition, a completely different part of the brain lights up. The part of the brain that lights up with chronic pain is that where we feel emotion. So the pain is psychosomatic because it involves the mind and the body, but it's legitimate, real pain. Patients must deal with the psychological, emotional, and cognitive aspects of pain if they're ever going to recover, regardless of physical and pharmacologic interventions that are undertaken. The chronification of pain refers to the process of the plastic changeable brain reorganizing around misguided signals. There is an increased upregulation of certain cells, glial cells, and these are the cells that support the nerve cells or neurons that are present in our brains. Also, there is a decrease in the body's ability to turn down the pain. Furthermore, there are chemical changes with increases in glutamate and NMDA, which are excitatory to the nervous system. Consequently, there is a decreased threshold for the pain signal, or an increased sensitivity, which results in light touch feeling more like a blowtorch. The emotions that arise due to chronic pain constitute the basis of suffering. The suffering increases because of the desire for the experience to be different than it is. Actually, fear of the pain is more disabling than the pain itself. The fear that it will hurt more results in fear avoidance, not moving because of the anticipation that it will hurt worse, resulting in less movement, and eventually the inability to move due to the formation of scar tissue, decreased circulation, and compression of nerves, which can cause, for example, a frozen shoulder or other joint that is immobilized. In addition to fear, the pain is stimulated by anxiety, anger, depression, and guilt. These conditions are worse in people, of course, with mental illness. Resistance makes pain worse. Trying to escape from the pain versus leaning in and simply allowing it to be there makes the pain less troublesome. The third fact about chronic pain, going back to some of Niki's key points, is that opioids simply aren't the best treatment of chronic pain and often make the pain worse. What we use to try to take the pain away, the opioids, also known as narcotics, actually can increase pain in several ways. These medications have been shown to cause inflammation in brain tissues, resulting in more pain while on the medicine than off the medicine. This is called Opiate-Induced Hyperalgesia. It's not easy to convince patients that this is occurring. This is a place where therapists and trusted counselors can impact people you are working with. Patients say to me, "Doc, I know that the opioids are helping. Sure, my pain is a 9 out of 10, 90% of the time, and I'm in bed 18 hours per day, I can't sleep, and I'm generally miserable. But when I don't take the pills, my pain level shoots up to the sky. So if you took my opioids away, I'd be worse." The fallacy here is that the opioids are working to diminish pain, when in fact the person is physiologically dependent on the opioids, so that stopping the opioid will temporarily make things worse because of withdrawal. Physical dependence and tolerance often result in a problematic relationship between the patient and the drug. This isn't necessarily addiction or substance use disorder, by the way. Substance use disorder involves the pathological pursuit of reward and or relief from the drug. I do see some patients caught up in a peculiar relationship with the medications, as I've mentioned before, so that continuing the drug results in continued problems. Opioids are perceived as pain relievers, and the salience of the effect is often compulsively pursued. Craving for the drug comes in the form of pain for these patients. The only two pain-free states are death and general anesthesia, and neither of these is the best treatment of chronic pain. If we are treating someone, we must consider the old axiom of measuring benefit versus harm. With opioids for chronic pain, the negatives outweigh the positives for the most part in most people. There are significant side effects, including but not limited to constipation, sleep apnea, hormonal and immune system changes, and cognitive changes. The dangers of overdose are increased with higher dose of opioids, particularly when sedatives like the benzodiazepine drugs, including Valium, Xanax, Klonopin, and others, are ingested along with opioids. Chronic opioid efficacy studies are few and far between. In one long-term study, half of the patients who had a prescription for opioids discontinued the drug within 6 months of having a prescription. The rest showed modest, if any, benefit for pain and little benefit for improved function. If on the drugs for 6 months, the likelihood of being on them for years is significant. Unfortunately, as prescriptions for opioids become harder to acquire, some patients are turning to heroin, which is cheaper and more potent. Overdose deaths from heroin are on the rise. Opioids are not the proper treatment of a sad, painful life, and they don't offer good treatment for suffering since they cause dysregulation in the emotional centers of the brain, affecting dopamine and other neurotransmitters. People on opioids experience a roller coaster of effect and opposite effect. Withdrawal, though usually not life-threatening, is quite unpleasant to say the least. Provisions must be made for detoxification or weaning under medical supervision. The next truth is that the treatment of pain must involve improving the patient's function, resulting in a better life. If we're going to treat pain, we ought to see evidence of improved function. There isn't any patient whose pain I can't take away if I give them enough pain medication, say Demerol or morphine. Everybody's pain would be absolutely gone, and you would all be unconscious. That's not proper, correct pain treatment. So instead of asking, what's your pain level, doctors and other clinicians ought to ask, how's your life? Are you walking? Are you hanging out with your kids and grandchildren? Are you able to work? If the answer is no, actually I stopped working 2 months ago and I'm in bed because the pain disables me, I'm tired all the time and I'm depressed, that's not proper pain treatment. And yet when we go to the doctor's office, the first question asked is, what's your pain score? If we're simply going after the pain, again, we're missing the boat. And the final truth is that expectations influence outcome in the course of chronic pain treatment. Our beliefs drive what happens to us, and that's the direct result of the power of the mind. Placebos are a good example of this. By simply believing a pill will reduce pain, 20% of those taking it would have decreased pain. This is comparable to some drug effects which might have an impact of maybe 30 or 35% versus 25%. These drugs get released on the market and somebody sells them, doctors prescribe them, and companies make billions while placebos are free. We should be capitalizing on this effect. There's another phenomenon related to the power of the mind known as nocebo. With a nocebo, the suggestion is negative. For example, take this pill and within 20 minutes, your stomach is going to start cramping. Nocebos are effective 90% of the time. So the power of the negative thought and negative beliefs is much stronger than the positive. That's a big part of the internal messaging with chronic pain and the chronic pain syndrome. I can't walk. My feet are on fire. My back is killing me. These are not the truth. But if we expect that they're not going to be able to walk, we create that reality for ourselves through our mindset. Pessimists have a more realistic view of life, perhaps, but optimists live longer, have lower pain scores, and enjoy a better life. So let's be optimistic and teach these skills to our patients. Furthermore, cognitive behavioral therapy is more effective if the patient believes it will be effective. What we think is going to happen is a lot more likely to happen because we think it is going to happen. This works in the negative way as well. Anticipating pain causes more pain. This is known as catastrophizing, which essentially magnifies the negative and makes the situation worse than it is. Catastrophization involves rumination of negative thoughts. It also involves pessimism, magnification of pain symptoms, and helplessness. Patients do better when they are engaged and distracted. Therefore, they are less affected by the pain. Of course, not everybody who has pain is in trouble. There are people who have chronic pain and manage their lives and go to work and function well. Other patients are said to have chronic pain syndrome, which is a constellation of symptoms that has been defined by the U.S. Commission on the Evaluation of Pain in 1987. Chronic pain syndrome includes pain for more than 6 months, and it also includes experiencing those emotions that we've been talking about, including depression, anger, anxiety, and fear. The pain results in restriction of daily activities, so people are in bed more than they're up. This also includes excessive use of medications and medical services, multiple non-productive tests, treatments, and surgeries. I can't tell you how many people come in and say, I'm getting off my opioids because my surgeon won't operate on me until I'm off. I ask, how many surgeries have you had on your back? And the answer is 4. This will be my 5th. Like the 5th is going to cut out the scar tissue causing the pain, and putting in new titanium rods to better fuse the spine will improve the situation. Rods that stabilize the spine by fusing it, preventing it from bending, are supposed to decrease the pain. Over the long haul, that is rarely the case, partly because the fix is unrealistic, and secondly, because as we've already decided, the pain is not coming from the back, it's coming from the brain. Finally, with chronic pain syndrome, there's also no clear relationship to the organic disorder, so as I've already said, these patients are misunderstood and not believed. Part of the reason we have so much trouble assessing pain is that pain is a totally subjective experience. The patient's pain is his or her own pain, whatever she or he says it is. There's no way to prove that the pain level isn't 8 out of 10. And as we've learned, a patient's subjective experience is different from another's. So we can only rely on the person's self-report, acknowledging that some people feel more pain than others. Treatment of chronic pain should focus on improving function, not simply reduction of pain. The problem with opioids is that if we're dealing with a broken leg, it makes good sense to take a limited dose of opioids for as short a time as possible. If one breaks their back and 2 years later they've developed degenerative disc disease and it hurts all the time, one must be very careful in making a decision to take opioids, since the pain is going to last the rest of his or her life. If the decision is to try them, well then let's try them as a clinical trial. Let's see how they work. How will we know if they work? Are we going to ask how the pain is? Of course, but as important is to ask how the patient is functioning. If she or he is up and around, going to work, sleeping better, and having better relationships, then that's a good trial. We should continually assess that on a regular basis, and if something changes and there is deterioration like less pain relief or impairment of function, consider discontinuing these drugs before things get worse. Opioids work, and they take the pain away, or at least decrease it temporarily. But over time, they stop working because of the development of tolerance, as Niki mentioned. So the dose must be increased to get an effect, which diminishes over time. If the patient wants to stop, he or she will have trouble because of physical dependence. We ought to have a plan to stop before we ever start. This is what I tell physicians when I train them. We need to have an exit strategy for how we will get people off these drugs if we start them, and we ought to implement that exit strategy if function is not improving or worse still is deteriorating. In other words, we, the system, the medical system, the therapeutic system, need some overhauling in the way we treat chronic pain. Opioids, as we've mentioned, have a lot of associated problems. The worst side effect, as I mentioned, is constipation. Doesn't sound that serious, but it is. I treated a woman who was 80 years old, had hurt her back working as a maid. She'd been treated with 80 milligrams of hydrocodone per day, and her constipation was so severe that the only way she could move her bowels was to put her hand up in her rectum every 10 days and manually disimpact herself. She was suicidal. We detoxed her off of hydrocodone, and by the end of the 12th day, she was free of constipation and free of opioids. Her pain score was reduced by 50%. Now, we all agree that this is a good news story, but we also can be encouraged that there are 2 new drugs released to treat opiate-induced constipation. Is that the solution to this problem? There are people who take opioids for their anxiety, fear, and sleep disturbance. I treated a woman who said, "Doc, since I started that hydrocodone, my marriage is better." That's not the proper use of opioids. I've already discussed the phenomenon called Opioid-Induced Hyperalgesia. This basically means that opioids cause more pain, and more physicians and medical practitioners are finally coming to realize that this is true. Clinicians can be most helpful to their patients in reviewing this information and developing a treatment plan consisting of decreasing or possibly discontinuing opioid medications. Treatments for chronic pain will be covered in this series, but the key interventions include changing thoughts and feelings using cognitive behavioral therapies, distress reduction skills, and mindfulness practices. Movement is key. Motion is lotion. So start slow and developing consistency with stretching, exercise, yoga, qigong, Pilates, or any number of other activities. Simply getting started with a daily walk would be terrific. By all means, consider avoiding toxic substances, especially nicotine and tobacco, which are associated with increased pain levels. And finally, giving up the expectation of being pain-free and accepting the reality of functioning better despite having pain will enable your patients to live a better life. And isn't that what this is all about?
Thank you, Mel, so much for your time and your insights and truths around treatment of chronic pain. And Niki, thank you for sharing your experience with us today. In closing, I'd like to remind everyone that in our next podcast in our series, we will continue the conversation about the science behind alternative pain management strategies and hear from two individuals who offer alternative treatments for chronic pain. And they will also share the interaction they have together as someone who provides treatment for chronic pain and someone who receives treatment for chronic pain. So our guests next time will be Jean Supin and Teresa Baltzell. Thank you again for joining us today and hope you can participate in the rest of our series.